morning. I'm Dr. Nithya, Assistant Professor in Department of OBG. So today we'll be seeing about one of the important gynecological cancers. So to start with, let's have a small introduction or a one-word description of various important gynecological cancers at a glance. So these four are the important gynecological cancers. One is cervical cancer, second is endometrial cancer, followed by ovarian and cancer vulva. So cervical cancer, if we take, it's one of the most important cancers because it is the most common one that we see in India. But when compared worldwide, uh, endometrial cancer and ovarian cancer, they are more when compared to cervical cancer. So cervical cancer, the very good thing about cervical cancer is that it is a preventable cancer. It has a very good effective screening program in place, and so there is also a good long duration between the onset of precancerous lesion and the development of malignancy from that. So it has a very effective screening program, and there is a universal screening program. So it's a easily preventable gynecological cancer. Whereas if you take endometrial cancer, then it's a good cancer. It's called as a good cancer because it relatively has a very benign course, and um, most of the patients, when they present to us, it will be in the early stage, so it will be easy to treat them at that point of time. Whereas if you take ovarian cancer, it is called as a killer cancer because most of the time the patients are asymptomatic or they have many non-specific GI symptoms. So they present to the gynecologist at the very late stages or at the stages where they actually have metastasis. So optimal cure in ovarian cancer is very rare. And taking cancer vulva, which is less commonly seen when compared to other three, but still when seen, it is seen as a very mutilating disease, causes a lot of local deformity and destruction. So moving on to endometrial cancer proper, I told that it's most common gynecological malignancy in developed countries. So overall, the world, if we take, it will be one of the important gynecological malignancy. Whereas it is the second most common in developing countries, only next to cervical cancer. The majority of women with endometrial cancer, they are diagnosed at an early stage. Distribution of the stage and diagnosis, if you see, most of them, around 68 to 70 percentage of them will be confined to the primary side, that is only to the uterus. And quite a few of them, say around 20%, will have a regional spread, like spread to nearby organs like bladder or rectum, or spread to the regional lymph nodes. And only a very few of them, like around 8%, they'll have distant metastasis. The incidence of endometrial cancer is very low in India, and the highest is being observed in Delhi, if you take India, and Bangalore, whereas in Mumbai it is 2.8 per 1 lakh. If you compare this incidence with the Western standards, it is much, much less. We see that in Western standards, at least for 1 lakh population, there will be 25.1 is the incidence. So, and the average age at the diagnosis of uterine cancer is usually around 60 years, that is in the postmenopausal age group. The lifetime risk of developing uterine cancer in a woman is 2.6 percentage. So if we classify endometrial carcinomas based on the pathological appearance, the most common variety that we see is endometrial carcinoma. For it has its own variants like biloglandular or papillary, secretory, and squamous differentiation. And the non-endometrioid histologies include mucinous, papillary serous, clear cell, squamous, undifferentiated carcinoma, and a mixed carcinoma. So the most common type of uterine cancer is adenocarcinoma of the endometrium. Two histological characteristics which differ in incidence, responsiveness to progesterone, and clinical behavior. So broadly, endometrial carcinoma is classified into two types, that is type 1 tumors and type 2 tumors. In general, what we have to know is type 1 tumors are usually benign. It's not benign, they have a benign course. Of course, they are malignant tumors, and type 2 tumors, which are non-endometrioid, then they have an aggressive course when compared to type 1 tumors. So what all comes under type 1 tumors? They have tumors of endometrioid histology that are grade 1 or 2. Again, in endometrioid histology, grade 3 goes to type 2 tumors, and mucinous carcinoma is also included in type 1, whereas the other non-endometrioid carcinomas are all included in type 2 along with the high grade endometrioid histology, that is grade 3. So the most of them, as I told you, they have a benign course. So 80% of the endometrial carcinomas usually come under type 1 tumors, and they are all etiologically estrogen dependent, and they have a favorable prognosis, and most of them are preceded by a intraepithelial neoplasm, that is atypical or a complex endometrial hyperplasia. Whereas if we take type 2 tumors, they account for only a small percentage, say 10 to 20% of the endometrial carcinomas. But they account for at least more than 50% of all the endometrial cancer related deaths. So as such, in endometrial carcinoma, death is rare because I told that they have a very benign course. But then if you take all the deaths that occurred due to endometrial cancer, then most of them are around at least more than 50% then are due to type 2 or non-endometrioid tumors. So this includes grade 3 endometrioid as well as tumors of non-endometrioid etiology like serous clear cell, squamous, transitional cell, mesonephric, and undifferentiated types. They are mostly high-grade tumors and they have poor prognosis. So they usually behave like ovarian cancers. They are clearly not associated with any estrogenic stimulation, and so a precursor lesion is usually very rare to identify in these kind of tumors. So as I told, endometrial carcinoma, the only main etiology is estrogen, estrogen, and estrogen. This unopposed estrogen exposure can happen due to many of the reasons. So few examples are Lynch syndrome. So Lynch syndrome is nothing but a familial cancer syndrome where there is a hyperestrogenic state and the patient is prone to many other carcinomas along with endometrial carcinomas. So what are the risk factors for a exposure to hyperestrogenic state? Early menarche or menopause. When the menopause is very late or when the menarche is very early, the patient is exposed to the estrogen for a very long period of time. So that is one of the risk factors. Or if a postmenopausal woman is taking hormone replacement therapy for any kind of postmenopausal symptoms, then again the patient is a high risk of developing endometrial carcinoma. Obesity, diabetes, and hypertension together are risk factors for the development of endometrial carcinoma, and this syndrome is called as corpus cancer syndrome. And nulliparity or polycystic ovarian syndrome, Lynch 2, as I told, and tamoxifen is one of the drugs given for chemotherapy of CA breast. So that again has a propensity to cause a hyperestrogenic state and development of carcinomas and hyperplasias. So tamoxifen is again nothing but a selective estrogen receptor modulator in standard doses. When used in adjuvant treatment of breast cancer, it is known to cause endometrial hyperplasias and polyps, even invasive endometrial carcinoma and uterine sarcoma. So pathologically, if you see, it just causes subepithelial stromal hypertrophy. So it gives a false impression of thick endometrium on ultrasound. So when you actually do an endometrial thickness for a patient who is on tamoxifen, it is invariably going to be high. But it's something that's false positive because when you sample such endometriums and then send it for pathology, almost there is a very poor correlation between the thickness and the abnormal pathology. So we generally do not evaluate such women who just have a thickened endometrium on ultrasound for patients who are on tamoxifen. So whom to evaluate? Only those who present symptomatically with abnormal uterine bleeding, especially in the postmenopausal age group. We have to evaluate them by doing the endometrial sampling. So a risk of developing endometrial carcinoma is estimated to be only 1.2 per 1,000 patient years after 5 years of tamoxifen intake. So many of the bodies like ACOG and Atlas, they recommend that tamoxifen may be extended to be used up to 10 years of time. So what is the precursor lesion for developing an endometrial carcinoma? Initially, all these agents are more prone to cause something called endometrial hyperplasia, where there is stromal and glandular hypertrophy. So again, it is of two types, simple hyperplasia and complex hyperplasia. So each of these types is again divided into without atypia and with atypia. So if you take the most benign variety, like simple hyperplasia without atypia, the risk of developing malignancy over a period of 20 years would be only 1%. And if you take this most complex variety, that is complex hyperplasia with atypia, the risk of developing a malignancy is almost equal to 30%. That is exactly 29% over a period of 20 years. So depending upon the endometrial histology, we have to offer them the correct treatment. Range 2 syndrome is nothing but a familial cancer syndrome. That is, it accounts for less than 5% of the total endometrial carcinomas. Hereditary non-polyposis colorectal cancer syndrome is the other name for this. It is a genetic disorder. It is the inheritance is through autosomal dominance. So what exactly happens in the gene level is that there are three important mismatch repair genes called MLH1, MSH2, and MSH6. So there happens a germline mutation in all these mismatched repair genes, and so that leads to microsatellite instability and development of multiple cancers in a single patient that runs through generations. So what are all the cancers that these patients are at a higher risk of developing? One is colorectal cancer, followed by endometrial, ovarian, gastric, even urethral and skin carcinomas. So if you take these patients, the lifetime risk of developing endometrial and colorectal cancer is going to be much higher than compared to the general population. So in general population, the lifetime risk is 2.5% when compared to that of a Lynch syndrome patient who has a lifetime risk of 40 to 60%. And also the age of onset of the cancer is also much less when compared to other things, general population. So I told that the average age of developing an endometrial carcinoma in a general population is usually for 60 years, whereas in a patient with Lynch syndrome, they develop at a much earlier age, like around 47 years, or sometimes even earlier in the premenopausal age group itself. So what exactly has to be done for these patients? Because we know that they are at a higher risk of developing these cancers, there are only two options that we are left with. Either we can do with thorough screening with pelvic examination, transvaginal ultrasound, and an endometrial biopsy. So this has to be done every year starting from the patient's age of 30 to 35 years. Or more safely, we can do a prophylactic total abdominal hysterectomy and bilateral salpingo-oophorectomy after completion of the childbearing for the patient. So that one is the most preferred alternative because we are removing the source of the carcinoma itself. So if these are the risk factors, then what is the protective factor? So before going to that, let's see why HRT is a risk factor. HRT has two components. One is estrogen and progesterone. Of course, only estrogen, when it is given unopposed, it increases the risk of endometrial hyperplasias and endometrial carcinomas. So why do we have to add that estrogen in the postmenopausal therapy? It has many benefits. It of course helps in relieving the postmenopausal symptoms like hot flashes, vaginal dryness, and it also prevents osteoporosis. Whereas the disadvantage is that when it is given unopposed without adding progesterone, 20 to 50% of the women will have developed endometrial hyperplasias after 1 year of unopposed estrogen. And the risk of endometrial cancer is related both to the duration and the dose of the treatment. So whenever we are giving HRT, what we have to remember is that we have to start with the lowest effective dose, and it has to be given only for a short period of time till the symptoms get subsided. So in any woman taking estrogen alone for 10 years or more, the endometrial cancer incidence goes drastically up from 1 per 1,000 to 42 per 1,000. Okay, what are the protective factors for endometrial carcinoma? Oral contraceptive pills. 1 year of use of oral contraceptive pills confers 30 to 50% of reduced risk. And this risk reduction is not just for that period of time. The risk reduction is extended up to 10 to 20 years from the period of conception of the oral contraceptive pills. Why? Because these oral contraceptive pills contain a combination of estrogen and progesterone is the one that has the chemoprotective role. Progesterone IUCDs are also available, like Mirena, which releases a small amount of progesterone every day from the storage, and it can be kept in place for up to 5 years. They also confer long-term protection. And the other factors which are protective are late menarche and early menopause, because they have a less exposure to estrogen, and smoking again reduces the amount of estrogen and offers a protection. Screening test. Do we have to really screen the general population with these kind of tests like pap smear, transvaginal sonography, endometrial biopsy with Vibra or Pipples? Yes, this is the big question, because there is no program or effective screening program in place for endometrial cancer like we have one for cervical cancer. Why? Because it is not so prevalent like cervical cancer in India. So any screening test that has to be in place should be acceptable, reproducible, valid, and cost effective. So if we take pap smear, it is a very insensitive tool. So it cannot pick up, the pickup rate for CA endometrium is much less, like around only 30%. So such an insensitive test cannot be in place for screening a general population. And if we take transvaginal sonography again, if we do ultrasound for screening general population, then it is going to be very, very cost ineffective, because it's an expensive investigation. And endometrial biopsy with Vibra aspirated or Pippel's curette again cannot be given for every patient, because it is an invasive procedure. So what exactly has to be done? When the screening is not in place, you have to diagnose it early and give the right treatment. That is the most easy or most appropriate way for dealing with cancer which doesn't have a screening program. So how can we diagnose it early? If a lady comes with premenopausal AUV, 25% of the endometrial cancers occur premenopausally. So this endometrium needs to be sampled, and even a small population like 5 to 10% can be under the age of 40 years. So any premenopausal patient who presents to us with AUV and she does not respond to the normal treatment that we give, then it is better to sample the endometrium. And all cases of postmenopausal bleeding, irrespective of the endometrial thickness or the ultrasound, needs endometrial sampling to rule out hyperplasias and carcinomas. Again, any patient with perimenopausal bleeding PV which is abnormal needs evaluation of the endometrium to rule out carcinomas. So the first step in the evaluation of endometrium will be office endometrial biopsy. There are a variety of instruments available for sampling the endometrium, like Novak's curette, Pippel's endometrial suction curette, and Vibra aspirator. Success of the procedure is affected by many of the factors. So these are usually office procedures or daycare procedures which does not require any anesthesia or analgesia. Can be done under local anesthesia, but if there are factors which will affect the procedure like cervical stenosis, alteration of the endometrial cavity by submucous fibroids, or there is an endometrial growth with a good size by itself, then we have to be careful. This procedure may not be succeeded. In otherwise, normal cavity with no such obstructing lesions, the yield of the office endometrial biopsy is usually good. And if we have to increase the yield of the biopsy, it is best combined with something called hysteroscopy, where we can put in a scope and visualize the endometrial cavity and take the biopsy under vision. So it again has all this endometrial sampling have a false negative rate around 10%. So if the if the endometrial biopsy report is normal and still the patient comes back to you with persistent symptoms or abnormal pelvic imaging, then we need to do further evaluation. So what else can be done before the pre-treatment evaluation. Another thing that is done is transvaginal ultrasound, which is a useful adjunct to office endometrial biopsy in the initial evaluation of endometrial pathology. So whenever the endometrial thickness is more than or equal to 5, especially in a postmenopausal woman, we need to be aware and evaluate the endometrial biopsy for ruling out carcinomas and hyperplasias. In the same note, we also have to be careful that type 2 endometrial cancers may have a thin endometrium because, as I told, because they usually don't develop in a hyperplastic endometrium or in an endometrium where there is estrogen exposure. So they usually develop in a background of atrophy. So not all thin endometriums are usually safe. Even in thin endometrium, if the patient is having persistent AUB, it needs to be evaluated and carcinomas have to be ruled out. They have a good negative predictive value but a poor positive predictive value. The other thing that can be done is a color Doppler along with a transvaginal ultrasound. So how does a fibroid or a polyp differentiate from a carcinoma? If it's a broad-based lesion with diffuse high level of vascularity, then it indicates a malignant lesion. Or if it is a focal lesion with a single feeding vessel in the stalk of the lesion with low vascularity, it indicates a benign condition like a fibroid or a polyp. Another thing that can be done is sonohystrography, which is good at detecting benign conditions, but the positive predictive value for a cancer is very poor. Again, like hysteroscopy and guided biopsy is very useful in smaller lesions and in tamoxifen-induced thick ET. So the concern is that if we do a hysteroscopy and take a biopsy, there could be a dissemination of cancer cells in the peritoneal cavity because in sonohystrography, we are going to inject saline into the uterine cavity. So, as per the NCCN guidelines and the ESMO guidelines, the initial evaluation of endometrial cancers, the recommended investigations are only clinical and gynecological examination along with the histopathology of endometrial biopsy, a CBC including a platelet count and chest X-ray to rule out any metastasis, liver function test and a renal function test. So, optional investigations which can be done are genetic counseling in women less than 50 years and those with a family history of endometrial cancer and colon cancer, so that conditions like HNPCC could be picked up earlier and further preventive measures can be undertaken. Or a cervical biopsy in MRA in suspected cases of cervical involvement. The CA125 MRI CECT in suspected extrauterine disease and the FDG-PT set, this is used in cases where we suspect distal metastasis. So all these are imagings, and when you have to, it also helps in determining the need for lymphadenectomy and radical hysterectomy or preoperative radiotherapy. To assess for hormonal treatment in women who are desirous of further childbearing and they want a conservative treatment for this early stage endometrial carcinoma, then these imaging are useful. If you can, what we exactly want to know from the imaging is whether there is a cervical stromal involvement or when there is a myometrial invasion or there is a distance spread. So ultrasound, MRI and CT are very good in picking up all this. And out of all these three, we see that the MRI is the most sensitive one, which can predict both cervical and myometrial invasion and the distance spread. Moving on to the surgical staging. For seeing endometrium, what is done is usually the surgical staging. So, including what all does the surgical staging include? Usually, general anesthesia is given to the patient, and a midline vertical incision liberally is given for abdominal exploration. The first step will be to take the peritoneal fluid for cytology or ascitic fluid if it is there, and if it's not there, you have to inject 100 ml of saline and take the peritoneal washings from all the areas to send it for cytology. Then we proceed with a hysterectomy along with bilateral salpingonephrectomy. selective pelvic and para-aortic lymphadenectomy. So what are the conditions in which we proceed with pelvic and para-aortic node dissection? When the tumor histology is of the type 2, that is grade 2 to 3 endometrioids, or any other non-endometrioid histologies like clear cell serous squamous, or if the myometrial invasion is more than 50%, or when there is a cervical extension, if the size of the tumor is more than 2 centimeters, and when there is an extrauterine disease. The risk of pelvic lymph node metastasis with grade and depth of the myometrial penetration is shown here. So we see that this grade 1 and 2, then the risk is very, very low. Only in pelvic node involvement is very less, that is 0 to 4%. Whereas in the high risk, when the depth of the myometrial invasion is more and when the grade is more, there is a high pelvic node involvement, that is 20 to 40%. So depending upon them, FIGO has offered a surgical staging. So stage 1 is tumor when it is confined to the corpus uteri. 1 is again divided into 1A and 1B. 1B when it is less than 50% of myometrial invasion or no invasion. 1B is more than or equal to 50% of myometrial invasion. It also includes the cervical glandular involvement. And stage 2, tumor invades the cervical stroma, but it does not extend beyond the uterus. Still, it is an early stage only. And stage 3 includes local or regional spread of the tumor. Stage 3 again has 3 types, A, B, and C. Stage 3A is cirrhosis of the uterus and adnexa. 3B is vaginal or parametrial involvement. And 3C is pelvic and para-aortic node involvement. Stage 4 includes bladder and mucosal involvement, bowel mucosal involvement. 4B is other areas of distant metastasis. So the surgical treatment is as follows. For stage 1 and again 1A grade 1 to 2 tumors, we do only a simple hysterectomy with bilateral salpingo-nephrectomy, whereas for 1A grade 3 and 1B we proceed with hysterectomy with bilateral salpingo-nephrectomy, and also along with that we do a lymphadenectomy for bilateral pelvic and para-aortic. And for stage 2, it is radical hysterectomy with bilateral salpingo-nephrectomy along with lymphadenectomy, both pelvic and para-aortic. For stage 3, it is maximal surgical cytoreduction. Stage 4, again, if bladder and bowel mucosas are involved, we do an anterior and posterior pelvic excenteration. And for stage 4B, it is systemic therapeutical approach with palliative surgery. So vaginal hysterectomy, what is the role in selective patients who are very extremely obese and have a poor medical status, and for patients with extensive retrovaginal prolapse, you can do a vaginal hysterectomy, but often bilateral salpingo-nephrectomy becomes technically difficult, and also abdominal exploration and lymph node sampling cannot be performed. So it is suitable only for patients with a low grade 1A disease. The prognostic factors, multiple have been identified for the high risk of recurrence in apparent early stage disease, like age, histological subtype, grade 3 histology, tumor size more than 2 centimeters, lymphovascular space invasion, myometrial invasion more than or equal to 50%, hormone receptor status, genetic and molecular tumor markers. So if any of these risk stratification is present, so stage 1 can be divided again based on these risks into low risk, intermediate, and high risk. This is for the post-op therapy. So in low risk, that is grade 1 and 2, we need to do only observation, and in the intermediate risk we can give only vaginal brachytherapy, whereas in the high risk group, which is stage 1B and grade 3, we have to give them pelvic RT. Whereas for stage 2, we give along with pelvic RT and vaginal VT, we have to give them, if any of these risk stratification factors are present, chemotherapy and post-operative radiation. Stage 3 to 4, again, paclitaxel and doxorubicin chemotherapy is given, and if the nodes are positive, then followed by sequential radiotherapy. So what is the role of fertility sparing treatment? Usually it is not a common scenario, but less than 10% cancers occur in women less than 40 years. So if they are usually well differentiated early endometrial carcinomas, so drugs that can be prescribed as high dose medroxyprogesterone acetate, 60 milligrams per day orally, and or megestrol acetate, 160 to 320 milligrams per day orally. There could be many side effects like thrombus formation because of the high dose of progesterone that we give, headache, mood alterations, weight gain, breast pain, or tenderness. Another convincing option is the LNG IUS, which would release a small amount of progesterone every day. But if the patient is offered a fertility sparing treatment, we have to make sure that they come for follow-up for endometrial sampling every 3 months to assess the response of the treatment. Women opting for conservative management should be aware that hormone therapy is not the standard form of management, and so regular follow-up is necessary. So follow-up after the treatment of endometrial carcinoma goes like